Good morning, everyone.
Good morning.
Welcome to this Ask the Doctor Zoom discussion with Doctors Craig Emmett Cole and Jamie Bernard. I'm Michelle or Mickey McWilliams. For those of you that don't know me, and there are a few this time that don't. Okay, and I'm losing my, hold on, losing my script here. There it is. And I'm trying to admit people too, so let me just do that. May I ask you first that if you're not speaking, please put yourself on mute so that when we're, so we don't hear backbeat noise. Before we begin our discussion, I'd first like to thank our very important partners, Oncopeptides, Karyopharm Therapeutics, Sanofi, Bristol Myers Squibb, Adaptive Biotechnologies, Amgen, Takeda, and Dova Pharmaceuticals. Without them, we wouldn't have the resources to reach out to multiple myeloma patients and provide this great discussion platform. I also want to acknowledge Sid Moss. Sid, wave. Wave. For those of you who haven't been on these calls before, Sid is the founder of Multiple Myeloma Corporation, and his organization is the one that's responsible for these healthy, not so healthy breakfast treats. Okay. It's hard to admit people and speak at the same time. Hold on. Taking in more people here. Okay, where'd it go? Recording. Pleased to have Doctors Cole and Bernard with us today. Dr. Cole is Assistant Professor of Medicine in the Division of Hematology and Oncology, Breslin Cancer Center at Michigan State University. He is Director of Clinical Research, Breslin Cancer Center, member of the International Myeloma Working Group, and Associate Director of the Michigan State University Center for Bleeding and Clotting Disorders. His interest includes plasma cell biology, smoldering myeloma, and novel therapies in multiple myeloma. Dr. Jamie Bernard is Assistant Professor, Department of Pharmacology and Toxicology at MSU. Her research focuses on early stage carcinogenesis caused by risk factors such as diet, obesity, and environmental exposures. She has just been awarded an ROI from the National Institute of Environmental Health and Science to study how obesity impacts the carcinogenicity of environmental chemicals. Dr. Cole and Dr. Bernard will explain how this research includes multiple myeloma. So first, we'll let Doctors Cole and Bernard tell you a little bit about their research, then we'll open it up to questions from you. Please use the chat button to type in a question anytime during our discussion. I'll read all questions sent to me in advance, and I have quite a few that have been sent to me in advance already. Plus, we'll unmute and take questions from the floor. Again, thank you for taking the time for the Zoom session. Welcome, Doctors Cole and Bernard.
Oh, thanks, Mickey. And I'm always, this is like my favorite, one of my favorite meetings. Because it's always so interactive, and I love just seeing everyone. So, so thanks for inviting us. And kind of, my research has been for, I guess, I hate to say decades in multiple myeloma. And over the past few years, there's really been an emphasis on identifying smoldering myeloma. And when you look at the amount of research that's been done in just plasma cell disorders in general, only 6% of the papers that have been published are on smoldering myeloma. The vast majority are on multiple myeloma, MGUS, some on amyloidosis. And basically everyone that has myeloma at some point has had smoldering myeloma. Even though that's controversial, we do know for sure that everyone that has myeloma at one point had MGUS that evolved into, or the monoclonal gammopathy of uncertain significance that developed myeloma. And it seems logical that that at some point that MGUS, where patients are asymptomatic and had a very low plasma cell burden, at some point those plasma cells expanded. There were more and more of those cells. They were behaving more ugly. They were briefly smoldering, and that brief can be months, years, or decades, and then evolve finally into symptomatic myeloma that we all treat. But it makes sense that maybe the point of intervention for multiple myeloma should be in smoldering myeloma. The trick about intervening in smoldering myeloma is that we don't know a whole lot about smoldering myeloma. And so one thing, and right now, when you look at some of the recent studies that have been done, they have really been applying multiple myeloma therapies and interventions to smoldering myeloma, when we really don't know how closely those two diseases are related biologically. And so Dr. Bernard and I kind of recognized that, gosh, there's not a lot that's understood about myeloma, about smoldering myeloma. We don't know much about myelomogenesis, or the biology that creates it. And something that has been seen over the past 5 years is how obesity is related to multiple myeloma outcomes. That the hypothesis is that adipose tissue cells, which is one of the biggest gland or endocrine organs in the body, can produce lots of cytokines that feed the growth of myeloma and impair the immune system against myeloma. The question is can we intervene in the obesity issue with smoldering myeloma early? To understand that, we need to understand the biology. And so when I had heard that Dr. Bernard was doing research in how adipose tissues release chemicals to promote cancer growth, literally I was driving from my office to the hospital, and I stopped at a at a Quick Trip or 7-Eleven or whatever in a parking lot, and then called in to say, gosh, this is really something that we need to study for smoldering myeloma. Because the dream would be if we can make that connection between smoldering myeloma and obesity, can we intervene with something like some of the new weight loss drugs that are available, some of the cytokine mediators that are available, maybe just recommending exercise and weight loss to smoldering patients, saying this can really have significant outcomes. And so that's the work that we want to do, is to get an understanding of the biology of smoldering myeloma, what makes it grow, and then being able to intercept it. Instead of using myeloma drugs to intercept smoldering myeloma, maybe we can do something a bit smarter.
Hi, everyone. I'm Jamie Bernard. I'm really excited to be here with you today. I will preface that I will probably not be able to answer any of your questions. I am not a physician, but I am a pharmacologist and toxicologist. I haven't studied cancer forever, but I got really interested in graduate school to understand how the environment impacts disease. And right now at MSU, I am studying how fat distribution in the body can impact breast cancer. And when I was talking to Dr. Cole about how little is known about smoldering myeloma and how much obesity is a risk factor for multiple myeloma, I was really interested in understanding, one, more about the disease, like Dr. Cole said, and two, if there are compounds that we could design that could block the malignant transformation of smoldering myeloma to multiple myeloma. So in my lab at MSU, we collaborate with a lot of the molecular plant biologists to create novel chemicals and compounds that aren't toxic, but can block the ability of a vulnerable cell from becoming a tumor cell. So we developed a high throughput screen that can identify compounds that prevent carcinogenesis. And I would also like to use that technology and apply it to multiple myeloma and smoldering myeloma. So I was so thrilled that Craig had stopped in the parking lot and asked me a bunch of questions. And we've been having regular meetings since March on our project, and actually have some really exciting preliminary data that I won't share today, but I'm interested to hear what your questions and concerns are. So I'm going to sit back and be a participant and listener, just like most of you. Of course, I'll be happy to answer any questions that you have on obesity and cancer. But thank you again for the invitation to come here.
So Dr. Cole, do you want to add anything to that, or should we just go right into questions that people have? Or do you want to talk a little bit more about what how this study is going, and like maybe how long it's going to take, when we'll learn about some of the findings?
We're really, designing the study right now, and trying to get all the bits and pieces together. I think it's gonna be a bit before we have any preliminary data. I know that Dr. Bernard has some already, but I think on a larger scale, it's gonna take a bit of time. But if you're a smoldering patient who is willing to participate, let us definitely know. You know where I live, so I think we can otherwise get right on into questions.
Okay, good. There are a bunch of them in the chat already, and if you want to, I can read them, or if you want.
I can read them off the chat. So the first one is a great question. They're all great, but the question that about the difference between auto-allo transplant and I can actually use that question to dovetail into CAR T therapies. And so a little bit of history. Back in the 80s, there was this idea that high doses of chemotherapy could cure cancer. And the idea was that if you can just give a high enough a dose of chemotherapy, that you can get rid of any cancer. And so the problem with that, you get to a high dose of chemotherapy, the bone marrow will be slow to recover or may not recover at all. So the easy thing, easy solution to that was, well, before you give that really high dose of chemotherapy, freeze off or remove some of the stem cells, that if you got, one or two stem cells, you could regrow a brand new bone marrow. And so the idea was, okay, we're going to harvest some of the stem cells, put it in the refrigerator, and then give somebody really high dose chemotherapy, obliterate the cancer, and then infuse stem cells from the patient that you saved. The bone marrow is empty because of all the chemotherapy, and that stem cell will regrow a brand new bone marrow. That's auto transplant, where the patient is their own donor for stem cells. The fortunate thing about the autologous or the self-donor high dose chemotherapy is that it was safe. And that it was safe to do, and the bone marrow grew back. And right now, the really bad outcomes associated with transplant for myeloma is very, very, very low, because we've been doing it since the 80s. The unfortunate thing is that the idea of high dose chemotherapy didn't cure patients of any disease, that it delayed the time that the cancer came back but didn't cure it. So then the idea was, well, what if we get a donor? Maybe possibly there was something wrong with the stem cells, and we should get a donor to donate the stem cells. And so what they did is the same thing, hydrotherapy, and instead of using the patient as the donor, they got the donor from a related person. And when those related stem cells got into the body, yes, it regrew a bone marrow. Example I like to give is that my sister and I get along. I give you that was, playing when she was in her goth mood or phase when we were teenagers. I was playing Cyndi Lauper and stuff just to irritate her. And so, I'll admit that I was a pain in the butt as a brother, because I just went out of my way to kind of poke at her. So if she was my stem cell donor, someone gave me high dose chemotherapy, I received her stem cells. Her stem cells would wake up in my body and say, what happened? Where am I? I'm not inside Bridget Cole anymore. I'm inside this guy. And the first thing her stem cells are going to do is cause graft versus host disease. Her stem cells will attack my lungs, causing graft versus host disease of the lung, my skin, some diarrhea. What her stem cells and T cells will really go after will be the cancer cells. That it will recognize those cancer cells as definitely something bad. My own immune system wasn't able to do that. That's the graft versus tumor effect. The great thing about the graft versus tumor effect is that it's very effective, that her T cells will kill my cancer cells dead, is that it's accompanied by graft versus host disease. So T cells attacking my skin and my gut and wreaking revenge for me playing Cyndi Lauper while she was playing Depeche Mode. She's still angry about that, actually. So then and that's an allogeneic transplant. Of an allogeneic transplant is really, it's an immune therapy. It's where her T cells wake up in my body and attack the cancer. And that's been done since really the 90s. And for myeloma, allotransplant was hit or miss. Sometimes the T cells would recognize the myeloma cells, sometimes they wouldn't. And when they didn't recognize the myeloma cells, then it's a very tough situation because the allotransplant didn't work. So you all graft versus tumor effect, all graft versus host disease, but no graft versus tumor effect. And then in 2010, somebody said, well, can I harvest my own T cells? If I'm the patient, can they get my T cells and reprogram my T cells to attack the cancer cells? The way that my sister's T cells would attack mine, if I got an allotransplant, why not re-educate my T cells to go after the cancer? The way they were able to do that is gene therapy, that you harvest my T cells, you insert a gene that will destroy the cancer cells that's commercially available, use those T cells back into my body, are guaranteed to have a graft versus tumor effect. Or those T cells, my T cells that were behaving, that were unable to recognize the myeloma, are able to do that. And that's CAR T. So CAR T is really a upgraded or another way to deliver an immune therapy similar to allotransplant, but without having the graft versus host disease associated with it. The great thing about the allotransplant is those T cells are going after tons of different markers on the myeloma cell. Right now for CAR T, we've only been able to do one at a time, so one marker at a time. Approved CAR T that's currently available, ABCMA, only directed towards the BCMA mark on the myeloma cells. In clinical trials, there are there are two-pronged or bispecific CAR Ts, there are trispecific CAR Ts. And so that technology is just exploding and will be very exciting. But that's the difference between an auto transplant. It's just a way to deliver high-dose chemotherapy that we use for, the vast majority of myeloma patients to put the disease off for the future. An allo transplant, when people have failed multiple therapies and we want to use the immune system to destroy the myeloma cells, so we get someone else's immune system to destroy it, like my sister, now we're friends. And now CAR T, which is a way to reprogram my own T cells to go after the myeloma cells. So that's that. The next question from Hal. Hal, I saw your picture on Facebook when you were in the Navy, and you are as handsome now as you were then. So I wish I had good pictures like that. How do you interpret COVID antibody test results? This 21 good. So one thing is that just last week, 10 days ago, actually, on the 16th, the FDA put out a message saying that the FDA warned providers and patients against using the COVID antibody assay to test for how well the immune system has responded to the vaccine. And it basically says that it's really too early to know what those results really mean, that we're still getting an idea of the dynamics of the antibody levels when patients are given the COVID vaccine, and how long does it take to go up, which is, I think we know pretty rapidly, but really, how long does it stay up, and does it ever go down? And so the FDA said that we just need to wait a bit longer to be able to interpret those results. And I think that's especially true for myeloma patients, because one thing that we really don't have a lot of data on yet are the dynamics of that test, meaning that how do we know, I guess for anybody, that I test my antibody level today, and it's 40, which is high, and then 4 weeks later I have a bee sting, my immune system reacts and my levels drop, and I was maybe given a false sense of security. And so the FDA about 10 days ago said, let's wait on interpreting those results, and that hopefully in the next 3 to 4 months, we'll get some more data on being able to interpret that. So I would, put a pin in that question, and then we can, I think, re-exploring that in the next few months will be, I think, a very important question. How many times is it possible to do an allogeneic transplant for blood cancer patients? So you can do, the most I've seen is 2. Where you can get it from different donors. So sometimes, like I mentioned, if I get a transplant for my and her T cells go after my cancer cells, if they get exhausted or if they can't recognize it, sometimes they'll pick a unrelated donor to do a transplant. Definitely an unrelated donor is not going to be happy in my body. If I had to get stem cells from my neighbor, then there'd be, his stem cells would be pretty upset that I let my dogs poop in his yard and stuff like that. And so I would have graft versus host disease all over the place and graft versus tumor effect, hopefully. And so I've seen 2 done. Is it different between extramedullary plasmacytoma involving the bone and non-bone? That's an interesting question. So there are 2 types of extramedullary plasmacytomas. And so there is extramedullary plasmacytoma, where it's a tumor of plasma cells that has somehow figured out how to live outside the bone or bone marrow. So myeloma cells are very different from other cancer cells, that they are extremely dependent upon the bone marrow stromal cells, and the cousin to the bone marrow stromal cells, the osteoclasts. So osteoclasts are in all the bones in our body. It helps to wear bone away in order to release calcium. And bone marrow stromal cells are inside the bone marrow, and they help support the growth of the bone marrow. Myeloma cells love bone marrow stromal cells. They can't live without them. One challenge that Dr. Bernard and I are going to have is trying to do experiments on myeloma cells when they need that microenvironment. They can't live outside the bone marrow. Sometimes those plasma cells can figure out a way to live outside of that by attaching to other types of cells. And those cells, and when that happens, you can have a plasma cell tumor. Instead of being in the bone causing a lytic lesion or in the bone marrow, it can be in the airways or in the skin or in the lungs. And that's extramedullary plasmacytoma. Sometimes that's all that patients have. And that is called a de novo or a extramedullary plasmacytoma without myeloma. That disease is usually treated with either radiation or surgical resection. And then you have to watch real carefully for them to have myeloma. If their bone marrow at the time didn't have myeloma in it, or plasma cells in it, then usually there's a 5 years, about half the people will end up having myeloma. If they have plasma cells in their bone marrow and extramedullary plasmacytoma, that's a little bit of a different disease, because that arose probably in the bone marrow and then moved out to these other areas and mutated out there. And those folks we have to watch really carefully, because their risk of having myeloma is a bit higher. And then what's really different, if somebody has had myeloma for a long time, and then after multiple therapies, they develop extramedullary plasmacytomas. That's because their original myeloma has mutated to such a degree that it's found a way to live outside the bone marrow compartment. And that's a higher risk disease. And when we've done studies and doing biopsies of extramedullary plasmacytomas, we find that their mutation burden, the number of things that have gone wrong in those plasma cells, is much, much higher than what is found with the original disease. And so when we see extramedullary plasmacytomas, we definitely attack that a bit more aggressively as being a high risk disease. And these days, what we would do is there are mutational assessments or next generation testing. So we've been doing fish studies on testing for, or fish cytogenetics to test for mutational burden for the past, 30 years, I think. Now we're doing next generation DNA sequencing to look for mutational burdens. And that's what we're doing now, to see what mutations have occurred to cause the extramedullary plasmacytoma, and are any of those high risk where we would or would not use different immune therapies or chemotherapies that are available today. What is in the works for those treated negatively for the antibody code? Yeah, so what is in the works for those that have tested negatively for antibody tests post-vaccines? Chris, I'm gonna say that's a really good question, because they're all really good questions. And that's a super good question, because I don't know the answer to that yet, because that really goes across the board. Depends a bit on which which vaccine that you got. And it, there's been rumors on and off about booster shots for the different vaccines. And so I think that's another question that, I put a pin in and recheck in the next 3 or 4 months. How do you approach high-risk lambda type myeloma? And so, myeloma cells usually produce antibodies. And so plasma cells, normal plasma cells produce antibodies. And so that's what they do. A normal plasma cell produces antibodies against things it doesn't like. When someone has myeloma, the plasma cells are mutated and they behave aggressively, but they still retain the ability to make antibody. If the plasma cells are really mutated, they'll forget how to make antibody and only produce fragments of antibody called light chains. And right now, there isn't really the approach to someone with light chain disease is to, again, assess the burden of mutations. And are there any high risk mutations? Can you make an argument for doing something different than the standard of care? If a patient has started out with myeloma producing a whole antibody and then ended up being mutated enough to produce light chains, again, we do look at that as a higher risk relapse. And we think about, maybe using more novel therapies for that group. The other thing about lambda light chain is to be cognizant that those lambda light chains can end up, instead of just floating around in the bloodstream minding their own business, they can float in the bloodstream and fold and insert themselves into tissues, causing a disease called amyloidosis or light chain amyloidosis. So every time I see a patient with, if a patient has just, standard IgG kappa myeloma, those whole antibodies are too big to fold and get into the tissues, but the light chains can. And so we have to, every time I see someone with light chain myeloma, I have to ask myself and be sure that they don't have amyloidosis, because that amyloid protein can get in the heart and cause really, really bad problems. And that's treated with, and amyloidosis is treated with a different regimen than we would use with multiple myeloma. The other feature about lambda light chain myeloma is that those light chains can just get stuck in the kidney. That the kidney, filters the plasma if that's floating around the blood. It filters out the chemicals and the waste products of the body. But those light chains can get stuck in the kidneys and cause kidney disease and cause kidney failure. So when a patient is relapsing with lambda light chain myeloma, my trigger to start therapy may be a bit sooner. So I know if I wait too long to retreat somebody with lambda light chain myeloma, those proteins can get stuck in the kidney. How do patients with myeloma doing the right decision on precision treatment by MDA, genomic analysis, or under your algorithms? We hear some patients failure with auto BMT more than once and are successfully have allogeneic stem cell. And some, that's very interesting. So this question is related to why is there such heterogeneity with multiple myeloma? I always, when I talk to the people we have in training, the fellows, I tell them how, there was, I did a talk in Colorado a few years ago, and I did my talk, this was, I think, in 2015, 16, did my talk, and this very pleasant lady came up to me, and she was in her 80s, I'm sorry. And she said, I had myeloma in the 70s. I got treated with dexamethasone for only 4 days of steroids, and I never received another treatment. And my first thought was, there's no way you had multiple myeloma in the 70s and got just steroids and it didn't relapse, because that's not the myeloma that I know. So the next year I go back, 2016, doing the same talk. And then she comes up to me again. And I thought, oh, she's going to say I did a nice talk. And then she shows me her bone marrow biopsy report. And I remember this, in 1978, and she had 50% plasma cells in her bone marrow. She had true and true myeloma. She had, one lytic lesion. She showed me an X-ray report. She said, I did have myeloma and I got 4 days of steroids and it never came back. And that taught me a really important lesson. That taught me that myeloma is very heterogeneous. The multiple and multiple myeloma means that every single patient is different with this disease. And some patients will have, I've treated just recently, I had 2 patients who were identical in every way. They, same cytogenetics, same mutational burden, same lytic lesions on their PET scan. I gave them identical therapy. One patient went into a complete response after 5 cycles of RVD. The other person, I'm struggling to get just a PR. The cells look the same under the microscope, same regimen, same everything, but behaving completely different. And that's really what we really need to work on. And that where did I put it? Where the cure cloud, if I can put that, from the MMRF is really looking to try and help us figure that out. That the standard way that we look at mutations in myeloma using fish cytogenetics, we've been doing since the 90s. And it is becoming a little archaic, I guess, I hate to say, even though I love my cytogenetics. And now we're able to do mutational burdens using next generation sequencing. And I think the answer to that question really does lie in being able to understand the mutational burden. The MMRF COMPASS study gave us some insight into that there are definitely the same myeloma that appears by fish studies and by looking under the microscope can be very different when looking at mutational burdens by next generation sequencing or other more modern testing. And then it will be, the future of myeloma is going to be in tailoring the new therapies, all the new therapies that we have to these mutations. Because right now we tailor therapy to fish cytogenetics. We do a lot of that we call high risk based on fish, but fish cytogenetics is a test from the 90s. And we're in 2021, we have much better technology to be able to discriminate who should get what therapy. It really is gathering enough data. So I would encourage people to sign up for the Cure Cloud study if you have measurable myeloma. And I think I can give Mickey the address to it. But if you have measurable myeloma, it'll help collect the data in real world patients to understand what the mutational burden of this disease is. Let's see.
Dr. Cole, I have a follow-up to that question. Is there differences in the way people metabolize that drug you talked about? And are they investigating that as well when they're interpreting the data?
That is every time I say, so great question.
You can tell me it's a terrible question. That's
no,
fine.
no. Great questions means that I can answer it. Super good questions means that we either I don't know or we haven't looked at it. So early on with Revlimid and bortezomib, we did look at how patients metabolize these drugs. and dexamethasone. And what has happened in kind of the interim of these therapies is that it's kind of fallen to the wayside, to be honest with you, and you're absolutely right in that we've been, as you know, in doing myeloma clinical trials for years and years, we really concentrate on the response to the therapy and not so much on how the metabolism handles it. If you look at some of the graveyard of therapies that didn't make it, some of those graveyard of therapies that didn't make it were based on metabolic differences in large number of patients. But I agree that I think that, you know, in the future, it's going to be super important for lots of patients to be involved in clinical trials to answer that question. So BiTEs, I love bispecific antibodies. And can I share my screen, Mickey? Let me show you something because over last week, there was a journal club of myeloma doctors from Carmanos, U of M, Henry Ford, and Michigan State. And we talked about CAR T and BiTEs. And I wanted to show you what a BiTE antibody is. So I'm going to show you a little cartoon. And here is hopefully the cartoon. And so do you see the antibodies on the screen? So at the top, there is a antibody against T cells. And so this antibody will grab onto T cells. It's an anti-CD3 antibody. At the bottom is a monoclonal antibody that's directed towards myeloma cells, BCMA. And BCMA is the target of all the new drugs in myeloma, the CAR T and all the CAR T trials, and blinatumab or Blenrep. And the colored portions of these are the business end. The sticky end of the antibody is in green for the T cells and in red for the myeloma cells. And so what they did is they engineered the two business ends, the two sticky ends of the T cell antibody and the anti-myeloma antibody together into a bispecific antibody or a BiTE antibody, where you have attached the sticky ends of a T cell antibody and the sticky end of an anti-myeloma antibody. And you can guess what that's going to do. That's going to pull a T cell together against a myeloma cell. It's going to bring those two together and force them together. So it's like putting my neighbor and I in a room, and then he gets angry that my dog pooped in his yard. And then what will happen is that there's a little thing on that antibody against the T cell that'll activate that T cell. And when activating the T cell, it will release its granules to destroy the myeloma cell. And that's a BiTE antibody. And the BiTE antibodies really do have incredible responses, and is probably, and the big question is that with the BiTE antibodies, it has the great thing about the BiTE antibodies, it engages the T cells in a similar way that an allogeneic transplant would, very similar to the way that a CAR T would. CAR Ts, you re-engineer a T cell to attack the myeloma cell. Well, why not you just force the myeloma cell and T cell together and then activate it without transfecting them and using gene therapy? And that's what the BiTE antibodies do. The advantage of the BiTE antibodies is that it's off the shelf. So With the CAR Ts, you have to wait about there's a CAR T, a product that we were looking at a clinical trial here that I was talking to someone last night about, and it takes about 4 weeks to engineer a CAR T to get my T cells to genetically re-engineer them and then give them back. Takes about 4 weeks. A BiTE antibody, I can just order it like any other drug. It infuses by the vein. The first dose has to be given in the hospital because patients can have the cytokine release, or those T cells get really angry when they're put against myeloma cells, and they'll cause fever and night sweats, and sometimes it can cause some swelling in the legs, and rarely, kidney problems. And so, but the good thing about it is that therapy can start right away, as opposed to the long term it takes for CAR T. And the responses are really actually very comparable. And so the big question, and the question that George gave is, who's going to win that battle? Is it going to be the CAR T or the BiTEs? And I would say that we're going to have both available because they're both, going full court press. I will not be surprised if a BiTE antibody is going to be approved by the FDA this year because of the really remarkable results that have come out of those studies. Very good question. Dr. Cole, after learning about my myeloma diagnosis, my sister sort of was tested and found of MGUS. Is that typical? So yes, patients that have multiple myeloma, their siblings do have a higher risk of having MGUS, or the monoclonal gammopathy of uncertain significance. We do not know how that happens. Is it something that is genetic that causes that? Or is it because that siblings usually grow up together and get exposed to things in the environment at the same time that causes that? It's not so much for children, it's more related to siblings. But there is some a risk to the children. The one thing, I think the important thing to know about this is that the MGUS, the monoclonal gammopathy of uncertain significance that occurs from patients that have myeloma, where their siblings have MGUS, or rarely the children have MGUS, is pretty standard MGUS, where their risk of developing myeloma is very low, about 1% per year of developing multiple myeloma. And so it's no different than anybody else. And so if your sister has MGUS, is she destined to have myeloma? The very high likelihood is no. But the good thing is that we know she has MGUS, so we can follow her. So having lytic bone disease and having bones break shouldn't happen because she'll be under observation. Dr. Cole, should genetic testing for potential secondary cancers be performed? Well, that's a very good question because I don't know the answer. I kind of do. Actually, there are very rare genetic diseases that would cause solid tumors in myeloma. Lee-Fermini is one very, very rare genetic disorder where people are prone to different types of cancer. The one kind of interesting thing is that the blood cancers genetically are on one side of the genetic street, and the solid tumors like BRCA1 and the other ones are very, very separate. And so there's not a lot of overlap between those. My spouse had carried multiple myeloma on the pancreas after a VRD, acupuncture, traditional medicine, maintenance therapy, collected stem cells. So kind of the question is, can you get a stem cell transplant after you've had your stem cells collected if you haven't used those stem cells? And the answer to that is yes. That there was a very important study that was done in France, the IFM study, where patients were either randomized to receive their stem cell transplant after 4 cycles of RVD versus getting the stem cell transplant whenever. And the good news about that trial is that it really didn't matter with overall survival if you got the stem cell transplant after 4 cycles or you got it later on. We usually recommend getting it after 4 or 5 cycles after a patient has achieved a VGPR, because the disease is at its lowest point, the mutational burden is about as low as it can get, and that the stem cell transplant, we usually just tag on with the induction therapy, but it can be used later on. Kind of the new place that we're using autologous stem cell transplant is when patients have had myeloma for years and years and decades, and their blood counts have gotten really low, and it's hard to give them more therapies because they've received 6, 7 different lines of therapy, is that you can do use those stem cells from 10 years ago to basically reinfuse a younger bone marrow. So if I save my bone marrow today, and then I get 5 different therapies for myeloma, I can get an auto transplant and receive my younger stem cells. I won't grow hair or anything like that. Wrinkles won't go away, but my blood counts will be as they were 10 years ago. Regarding the research on obesity and smoldering myeloma, are there specific, this is a question for Dr. Bernard. Regarding the research on obesity and smoldering myeloma, are there specific adipocytokines involved in it, in its pathogenesis? And if so, how are they unique to myeloma? Ooh.
That is a great question. So far, they haven't identified anything from an adipocyte that's unique for driving multiple myeloma. But there has been a lot of redundancy with what they've seen with other cancers. So an adipocyte can be kind of like an energy source. And the first studies were done from adipocytes that are actually in the bone marrow. So when you think of an energy source, this cell is releasing growth factors, which could be proteins. Also, it's rich in lipids and fatty acids, which provide energy for cells to divide. And also pro-inflammatory cytokines, one such as interleukin-6. Now, most of this study's been done in animal models, not really in humans. So how translational this is, we don't really know yet. Perhaps really interesting would be to understand how fat cells in other places of the body actually promote the cancer from forming in the first place. But I think there is potential for unique targets for multiple myeloma, since this is a different type of cancer than, say, a solid tumor. So the contribution of each of these factors from fat cells might be different for the different cancers, and that's something that we're seeking to understand.
Very good. George is cranking out the just incredibly difficult questions. In fact, I have to fan myself a bit because those are some awesome questions. Is it possible to have liquid biopsies from regular blood or serum by using mass spec in the future? So so do we have to do bone marrow biopsy? We've been doing bone marrow biopsies for myeloma for the past 157 years. So very, 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 very long. Since we discovered the disease, we've been doing bone marrow biopsies for myeloma. And really the IMF and the MMRF have been spearheading an effort to be able to diagnose myeloma and to test the mutational burden without doing a bone marrow. So again, the Cure Cloud study only uses blood, because what we know is that myeloma cells actually will shed their DNA into the bloodstream, and you can test for those specific mutations in the blood, which will basically be equivalent to a bone marrow biopsy. And so we'll have to, so that those efforts are underway. There's a lot of research really trying to eliminate the bone marrow biopsy as a test for this disease. Mass spec is funny because I was at a meeting, and I guess as in regard, this answers the question too, with the FDA and the American Academy of Cancer Research. And the FDA is like, why are you guys doing a bone marrow test from 1800 and you're doing a blood test, and urine test, also from the 1800s and 1900s? Why are you still doing that for myeloma research in 2020 or 2021? And that was a very good question for us. And it took all of us kind of by surprise because they're right. And the SPEP, the main test that we use to measure someone's myeloma is a test from the 60s, from the 50s really. Mass spec is a way to detect those antibody levels much better. Mass spec just can measure the amount of that protein based on its molecular weight. And it is able to detect very, very small amounts of myeloma protein. And there was an abstract that was at, I think, ASH or ASCO last year that saw that may be a way to identify MRD, or minimum residual disease. And so I have told everyone that not only are patients asking for better ways to measure this disease, but now the FDA is asking us to do it, which I think which makes me think that change is going to come in the next few years. I love venetoclax. Venetoclax is a BCL2 inhibitor so myeloma cells, the way that some myeloma cells stay alive is using a protein called BCL2. If you take that away, the myeloma cells die. This only works for patients that have a specific cytogenetic abnormality, the translocation of 11 and 14. Fantastic results. And so very, very, very exciting. And I think that I have 1 minute left, so I think I'll stop there.
There are a couple questions that were sent to me earlier. One, I want to make sure that we ask you this, and that is because what you've said and other doctors have said it as well, don't know the efficiency of the vaccines for COVID-19, and we're not sure about what to do. What do you recommend patients do in the meantime while we're waiting these few months to find out how effective these vaccines are?
So definitely get the vaccine. And second is that I would still, take the precautions. So, would I go to Lollapalooza in Chicago this year in July? I'm not going because that's just too many people. But I wouldn't go to Lollapalooza. And, I would still, the social distancing. But I think the one thing is that other people that have been vaccinated is to really encourage family members to be vaccinated, because the data is kind of mounting that other people who are vaccinated can't carry the disease from person to person. And so having people around you vaccinated, encouraging people to be vaccinated, continuing to do some level of social distancing, but bringing in some of the people who've been vaccinated may be a little bit closer.
Thank you. So do you have a couple more minutes, or are we pretty much done?
Oh, a couple more minutes.
A question that I was sent an email to is, please ask doctor to discuss lytic lesions and the relationship to rib pain.
So rib pain, so the myeloma cells, again, will attach to osteoclasts anywhere. And they're osteoclasts in every bone, including in the ribs. And so those myeloma cells can attach to those lytic lesions attach those osteoclasts and cause the bone to wear away and to get soft, which can cause a rib pain. Another way that, so that's, the obvious kind of, classic way that myeloma can cause it. Also, patients can have referred pain from spine disease. And this is the kind of tricky thing, is that sometimes patients can have rib pain from the ribs themselves. Sometimes they can have referred pain from the spine. And so spinal stenosis or lytic lesions in the spine can involve the nerve going to the rib. And it feels like the pain is in the rib when it's really coming from the spine. And then the last thing is that patients can have pain in a different area. And so in the low part of the spine, they have to compensate for that pain by twisting to the side, which can then cause rib pain, not because the rib is involved, but because they have to compensate and move around for pain elsewhere.
One more question I have here is, would it make sense to assess a patient for minimum residual disease to determine if a patient could stop maintenance therapy to prevent secondary malignancies?
So I guess one important point is that I want to say that was 2006, I think, or maybe 2008. The FDA became aware of the secondary malignancy risk associated with Revlimid maintenance. And so a big investigation took place back then to see what is the safety of Revlimid maintenance. What they found is that the benefit of Revlimid maintenance way outstripped the risk of secondary malignancy. And so there was a brief hold on Revlimid maintenance. The FDA did this investigation and saw that the benefits for maintenance therapy were so great and the risks were so small of secondary malignancy that they reopened it back up. The risk of a secondary malignancy from Revlimid maintenance are primarily the benign cancers of the skin, like basal cell and squamous cell, where you get those burned off. There are more serious malignancies associated with it. And so I always recommend that my patients, go and get their usual screening tests, their mammogram, their colonoscopies and such, to make sure of that. But the cancers associated with that are are not the big bad cancers. The risk of dying from a secondary malignancy was less than 1%. The risk of dying from withholding the Revlimid maintenance was much, much higher of that. And that's why we recommend Revlimid maintenance. But we always watch very closely for skin exams and for monitoring for other cancers. Those studies looking at when can we stop are underway right now. And I just heard this morning when I read a Twitter feed that maybe at the ASH meeting in December, that we may have a readout on that answer. And so someone's preparing an abstract for ASH regarding maintenance therapy and MRD.
Well, we are over our time. So I think that we should probably stop it here, but wow, very, very interesting discussion, Dr. Cole, thank you. And if you and Jamie, both of you just stay on with Sid, so we can all four of us talk a little bit about your project.
Yes.
And then for everyone else, thank you so much for participating. We look forward to seeing you again soon. And I'll have more information about our next discussion soon. And hopefully we'll have some more information about what we're going to do with Wine and Dine in the D pretty soon as well. So have a good day, everyone. And I will talk to you soon.
Thanks, everybody.
Bye.
Thank you.
All right, how do we leave?